that during this?
No.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. We have no public, so I guess we have no public comments at the moment. Consent agenda. Everybody satisfied?
So move to be approved as presented.
I'll second.
Moved and seconded. Those in favor?
Aye.
Aye. Thank you. Did you say aye, Judy?
No, I was eating, but I'm sorry.
She said,
I caught you. Okay, we have Cheryl's going to give us a report.
So first on the agenda was the AT&T contract, is that right? Oh, that's the last thing, okay. Okay. All right, well then. The financial report for July 2016. All right, so, our patient count for July, this is year-to-date, of course, there's only 1 month in the year-to-date. Very comparable year over year. Are a little bit low for inpatients this year over last year. Otherwise, those numbers are pretty close. Lab exams were down a little bit. Radiology was down quite a bit. Rehab was way up year over year. We added those staff, that's amazing. This is actually a true number. I had to go back and really look that up. I don't know what happened this month. It was a crazy good month last year. Home health and hospice at 80 visits is really a nice number, an average number, so it just looks bad, but it's really not. Health clinic, pretty steady. In my mind, still a little bit of slow with the absences we've been dealing with providers being out. Yeah, because I think we could do, closer to 915,000 if life was all really good. Okay, so this is our monthly revenue, and I did stack it up a little bit differently. I thought this would be interesting, and it's not really great for a PowerPoint because it'd be hard to absorb, but in your spare time, when you're wanting to think about this, I think it's good information. Our average monthly revenue last year was 2.4 million. The month of July, we had 2.476 million. So a good month revenue-wise. Our days in AR, it doesn't show up on a graph like this, but it would be right here at 85. So it is up again and staying up. So two things I want to say about that. There is a backlog of mostly one doctor that creates 10 days of AR that I have absolutely no control over. So in our defense, I mean, we're looking really at 75 days that we should be doing better at 60. We have really struggled with this, and we actually have found a revenue cycle consultant that we hope might be able to come in and give us some great advice on how we could actually get those days down by another 15 where it really should be. So I hope that we'll get that information in the next month and start seeing some improvement here. Okay. Collections on our accounts receivable for the month was 1.679 million. The average last year was 1.83 million. So it really wasn't a very good month in collections. This month, August, is up a little bit, but still not quite as high as I would have liked to see it.
That's a reflection of the AR collections.
It is a reflection of the days in AR. It's also, I mean, another part of it that I think we can't forget is that as we increase our charges, so do our contractuals increase. So part of this increase is due to our contractuals being higher, because we charge higher dollars, but we still get the same amount from Medicare or Medicaid. We get more from Blue Cross because we increased our charges, but we don't get more from Medicare and Medicaid. We have to charge everybody the same, so our contractuals go up. Our gross
Until
revenue goes
December
up.
when we settle up, right?
Huh?
Until December when we settle up.
Well, that's true. we might, yeah, you're right, we do have a true up when we get our cost report money from Medicare. But maybe not the entire difference.
Correct.
Yeah, okay. So, and then looking at days cash on hand. Today, July 30th, we have days cash on hand of 122 days, which doesn't really look good in the greater scheme of things. However, if you add back the amount that we have spent on the construction build so far, the money that we are gonna get back in October after we borrow the money from, when we do the bond, that would bring our days in AR up to 140. And also in September, we have received $800,000 towards behavioral health. And realize we are spending money on computers and staff and, paying the staff, and we haven't really gotten any money from behavioral health yet. So that's gonna make, that adds almost another 15 days. So,
Cheryl, I thought the behavioral health money was really going to kind of stay separated.
that is not my understanding. We know how much we're getting, and we have a department, we'll have a separate department in our financials, behavioral health. It is a department of the hospital, so next month you'll see a department on your DL, it's behavioral health. And so we will be tracking, really the direct cost that we spend on behavioral health. And then if you wanted to, you could come up with an allocation of overhead, just like you do for other things. So we would be able to account it, and I'm certainly not advocating going out and spending that money. But it is gonna add to our pool of cash, and there are no restrictions on it.
But in your department, you do need to put that overhead so that we can keep track that we spent the money directly to the state.
Yeah. Yeah, we don't do that for other departments.
No, but this is
We can
special.
try, if you wanna do that. Yep,
Yeah.
I can come up with something.
We don't want to run afoul of any of the OMARs.
No, I know, but I have looked into that. I am definitely aware of what issues there might be around that, but as far as I can tell, there are no written hard, fast rules that say you have to do this, or that. So, anyway. And also, I don't think from the bank's perspective, they're not gonna see that, since there are no written covenants, they're just gonna see this much cash, and this is where you are, so.
That's good.
Yeah, that's good
Well,
for
my
us.
concern was just that we try to balance, balancing isn't the right word, but my concern is that we know the amount of money that comes into us for behavioral health and what we are in turn spending on behavioral health. Hoping that stands on its own feet.
Yes, yes. Well, I would like to see that we are going to have to invest some money as we bring in new staff before they all get up to speed as far as seeing patients and getting the revenue engine running, so to speak. There will be a little bit of a lag, but they have plenty of cash to finance that. But yeah, you're right. I think we'll see it be
I think we all
More
want
than
to
a
see it
break-even.
separated out.
yeah.
We'll be able to show that to them.
Well, if we're ever challenged by the state that we spent their money on behavioral health, that's what we have to prove.
This is not expense, this is just cash. The expenses will go to these, and the revenue coming in.
The revenue will be separate. The direct expenses will be separate. We can figure out overhead.
It was my understanding the county had a carryover pretty big figure. Is that going to come into us contractually?
Yes.
Okay.
I'll address it in a moment.
Okay.
Okay. So then, looking at our profit and loss actual versus budget, our revenue was under by 19,000. Our expenses were over by 19,000. Less depreciation and interest, which were under. So we had an operating loss of 180, budgeted at loss of 154. But the bottom line is we had a positive net gain of $1,600. We're $18,000 behind budget. Not bad. given that we have already been spending money on mental health, not really.
That's just a 1 month shot too. so
Yes,
it's
I
gonna
know, it's hard to tell.
Okay.
It is hard to tell. And then the balance sheet, you see cash going down a bit. AR is up a bit, like you kind of expect. Otherwise, no real change month to month. AP liabilities are up, but, you know, we have, those construction bills are between $400,000 and $600,000, so the timing of those has a huge impact on our current AP balance. All right, questions on?
I noticed the clinic was down quite a ways this month.
Profitability numbers?
It was about 50,000 in the whole this month, but it is positive for last year.
Yeah. I don't know the answer to that off the top of my head. I can look into it and I'll get back to you.
Isn't that
Okay?
where Chris goes in the clinic?
Yeah, Chris was out, yeah, and it was huge. We did have locums in, but of course, they're very expensive. But let me look at that specifically and I'll get back to you. Okay.
Can I ask you a question on that? Back to the days in AR, and the number of days you have cash on hand. We have some sort of a, with the bank that we have to have 120. Number was,
Yeah.
it's 121, so
120.
22.
22. So do you have to report that?
We have to report them, sorry, go ahead.
Isn't that at a specific date at the
Yeah.
end of the year?
Okay.
So in the interim, I don't think
They
it.
don't ask you ongoing.
No, we do provide them sometimes quarterly financials. With the new financing we're looking at, there will be a little bit higher reporting requirements, like more like quarterly and fill out a certificate to say that yes, we did achieve these things. So they'll be watching a little closer than they have, because it's pretty relaxed right now.
Okay. Sorry, I didn't back up.
Nope.
Also, they are certainly aware that we are paying for construction costs
Yeah, that's
during
true.
this time.
Oh, what? Oh, okay, now I got a few people. Go in order. Okay. The AT&T contract that you all received, in a kind of a last minute sort of thing, we had to upgrade our TV, I don't know what you call it, our TV service, because they're all going away from, they're going to digital.
So what happened is Charter changed its deal, and we had to either invest a bunch of money in Charter or change and go to DirecTV, which is AT&T. And that came, we had talked about switching out from cable to DirecTV over time. For several years, we've looked at that, and then we were forced to make a decision. It appeared that this DirecTV would be a better deal for the district.
Not matter, $500 or
Well, for
$479 a month.
for the same TV, essentially, I mean, the prior provider wanted a $25,000 investment in it to bring us the new equipment. And so, yeah, this was clearly a much better deal. And so we did decide to go with AT&T, DirecTV, and they would like the board's okay on the lease. They wanted the attorney's approval and they wanted the board's approval.
Well, you've already signed for it, so I hope you can pay.
We either had to go ahead and get it or have no TV, and I didn't want to be the one to tell the hospital inpatients that there would be no TV.
What about like the gardens? Does it cover everything in the hospital? What if we add some more?
He said it's no big deal, it'd be the same price. I mean, I asked that question.
One price
too,
for the
because
whole
we-
system?
It's the price for the same
Wow.
system.
Good.
We're still struggling with a couple of channels because there are some differences.
Lois get her channel yet, Charlie?
As of this morning, there was some
I think somebody's
concern
working on that.
about whether or not that was actually covered under the dish, that they were checking a different option.
ABC, is that the one that's out? They're on strike, right there. They're fighting.
I watched the
Could I have a motion to accept this contract?
What was the length of the contract, Chuck?
60 months.
Yeah, 5 years.
5 years. Anybody want to?
I'll go ahead and move we accept the contract as presented.
I haven't read it. I have to tell you guys, I was not home today.
That's okay.
And
It's
I-
We're sorry that,
I am behind the 8 ball.
It's a,
So
it's
was I,
a really
so-
ordinary lease. It's really weird. I thought in my mind it's a very straightforward lease.
we looked at the lease in it, and I signed the lease.
And Jim
thinking
reviewed it.
This
like
was fine.
460 something a month.
479 a month for 60
479,
months.
yeah. That's pretty straightforward.
Why they require a board of directors to approve it? Can't
And
explain.
and they actually installed the equipment before I even signed the lease because it was do or die.
All
So
right.
they were good enough to come out and just put it in, which I know they want the business, but still.
Well, I did look at it, but my concern here again was with going to provide the channels that some of the long-term care residents felt were very important. I don't know whether that's issue's been addressed, it's
We're
evidently not.
working on it. We
Yeah,
thought we
we are.
would have it resolved.
We
What we have is, not all
were
channels are
helped
requested by
choose,
everybody.
right?
Right.
Yeah.
And so that what we got was a series of, you know, and it's a communal.
Can't
And
please
so many
everybody.
people want these channels.
We did see.
So we're still working on resolving the issue.
Because I've been afraid to visit Lois. Know the PBS is back on.
Larry.
Larry might be there.
I spoke with a representative from DirecTV, and we cannot get that channel that Lewis wants right now at this moment, because they don't have a contract with that channel.
Well, then I'm not gonna second it.
I'll second that.
Please.
Send a rabbit ears.
All right, moved and seconded that we accept the AT&T contract. Those in favor? Aye. Aye. Thank you. Okay.
Maybe we can get a
Cheryl,
little
you're still on.
antenna for Lois. Yeah.
Because you can't get it.
Yeah. I just need some rabbit ears.
Okay, so, speaking of Lakeview Gardens, they had a fairly good average month, year over year. The revenue was very good year over year. The revenue was 173. Their average last year, last year was 160,000. It's good. So their P&L for the month was good because their revenue was good. They had a net profit of $18,000, which gives us evidence that 1 or 2 extra people in there makes a big difference. And their balance sheet did not change very much. They have probably more cash than they should have at the end of the month, because we transfer it about once a month to try to keep that down and lower the payable to Lake Health District. But otherwise, kind of average. All right, Goose Lake Medical. This is their current month. They had another pretty good month. At 55,000, makes a big, big difference to have an FMP down there working full time. It really does. So, they ended the month with a net gain of $12,000. We could just keep this up every month, life could really start to be grand. Tony's doing really well down there. We've got plans to keep building the business to, Juanita has planned kind of a health fair day, and what we're gonna do is like have a bouncy house and try to attract kids, because really, kids are underserved in Alturas, and we could get a lot of kids. So, you know, we're kinda almost ready to start doing the vaccinations. And Tony is liking it down there, and people are liking him, and he's just going like crazy. So it's exciting.
Question, do they do any of these sports physicals down there, do a free thing, and trying to get into the community that way?
I don't think we've done that yet. I think that's a great idea, and I think Tony would love to do it. I don't think that Stevens or Gilbertson have done that kind of thing, and they need that.
Great PR.
Yeah, that's a great idea. I'll make sure, I'm pretty sure we're planning to do that, but I'll ask.
We did several years ago when we had another nurse practitioner here. But we had, when he left, we did have someone that was interested. But we can definitely take that. We certainly do that here.
Yeah. Yeah, for next year, yeah. So, any questions for me?
What hours are we open down there
Right now, it's pretty much an 8 to 5, but at least we've got 5 days a week now. And just having providers there on Friday is awesome. August might be a little bit tough for us because Dr. Gilbertson has been out the entire month after surgery. But I don't think it'll be as big as it could be because she doesn't see that many patients.
And I had said that we were going to have a physician starting in July as a locum, and at the last minute, she didn't.
Well, it's nice to see a bit of a gain in July.
Yeah, well, then it's possible. You know, with a FNP seeing 15 to 20 patients a day, it's just entirely possible. And it could just get better from there. I mean, I bet we could add a whole nother provider to keep them busy full time and not really have to add any support to that. So,
Very good.
okay. And the board designates.
Last part, you want more time? Last thing on our agenda we have for Goose Lake Medical is that we've had a resignation from serving on that Goose Lake Board of Directors. If you recall, we have 2 members that are from our board that serve on Goose Lake, and Chuck has indicated that he's not able to continue serving in that role. So
And I'd like somebody else to get the experience too. So, which one of you would like to do that?
Shane's not here.
I'd second that.
I was thinking about Gerald on this because he's got a lot of interest in that Lakeview Gardens. Is that something you'd be interested in, Gerald?
Tell me the time commitment.
That's not much, really.
we meet about quarterly. And we show you all the financials at this meeting. There are occasions that you would have to sign a check, a couple checks. But it's not an enormous commitment of time.
It is not a huge commitment.
No, Judy's the president, or chairman. I move that we accept Gerald.
I'll second that motion.
Goes in favor. Aye. Thank you, Gerald. Now comes the interesting part. Washington federal bond. And John's here from Blue Rose to explain it all to us.
Plain English.
You're
You're dressed way too nice for Lakeview, but that's.
Well, when I walked out of my hotel to come here, I figured as much, but I knew I would be recorded today, so I wanted to look my best.
We're not judging.
That's fine.
Speak for yourself.
I like it. I like that he's professional.
Board of Directors, thank you for having me here today. It's been a pleasure serving your district over the past few months, working closely with Charlie and Cheryl. We've done a lot of work. We've covered a lot of ground in the last 3 months. And I'm here to answer your questions and bring you up to speed on where we stand with Washington Federal on the Series 2016 bond. Blue Rose is your financial advisor, has been negotiating with Washington Federal for the last, really since the end of July, probably about a month to 6 weeks. And that's in the credit request of $14 million. In working with Charlie and Cheryl, we've identified certain capital projects, certain strategic investments for the district that are moving forward or will move forward in the near term. And we want to secure financing today for those projects. The bank has come back to us with an attractive commitment letter. We're on version 5 of the commitment letter, demonstrating the amount of negotiation that's going on here. Just kind of each time asking questions, getting to an incrementally better position for the district. I think we're very close. I think we're right there to execute, or execution ready. There is one remaining item that I'll address that would go in your favor, and I think is likely. But again, the terms and pricing are attractive. They're attractive today relative to the bond that you closed last year in October, the 2015 A bond. And that bond is outstanding currently in the amount of about $13 million. When Blue Rose was first engaged, we looked closely at the 15A bond, the transcript, those documents, the commitment, the original commitment letter, just to get a feel for what Washington Federal had offered, and how that deal ultimately closed. There was also the Series 2015 B bond of $5.5 million that never moved forward, and that's now sort of a component or a part of what we're now pursuing. So it's not that we're requesting $14 million new, and the bank had effectively committed to $5.5 million already. So we've been moving that forward, and that $5.5 million was associated with the long-term care and assisted living facility. So in understanding that transaction and sort of applying our market knowledge and working with Washington Federal specifically, or banks like Washington Federal, we moved ahead in negotiating with them directly, feeling that there were areas for improvement where we might improve and meet many of your objectives. And I list some of those objectives here at the bottom. $14 million commitment was important. To pursue another 10-year fixed interest rate, nominally adjustable rate over those 10 years fixed. 25-year amortization. We wanted it to be a drawdown facility, very similar to how the 15B bond was structured. Meaning, instead of them wiring you $14 million for your project up front and the interest begins to accrue on that, but yet that money hasn't been spent, now you can draw it down and you're avoiding some interest as you go.
More like a line of credit.
Yeah, it's like, and then at the end of 2 years, that draw period ends and you convert to an amortizing principal and interest schedule on a 25-year amortization from that point forward. So actually the final maturity on this bond is 27 years, 2 plus 25.
What's the fixed rate for the first 10 years?
Current market, we haven't locked the rate yet,
Okay.
but currently it's 2.74. Very attractive. I mean,
So do you amortize?
I have a good chart in here I'll show you showing rates since the beginning of 2015 to today, and it's
That's a little confusing to me if you got a 10-year commitment, but you're amortizing 25 years.
right.
That
I can
essentially,
explain.
you can change, okay,
Sure.
the interest rate can change, but
So, right, at the end of 10 years. So practically speaking, it's a 10-year rate today to 10 years from now, 2.74. The first 2 years are interest only at the 2.74. So as you draw, interest will accrue at 2.74% monthly. At the end of the second year, however much money the district has drawn will be set. That's your principal amount on the bond. And we will calculate, there will be a calculation, a 25-year amortization schedule, what your monthly payments will be in principal and interest. But the bank is only committing through the end of 10 years, or 8 more years, if that makes sense. So there is a balloon, there is a certain amount of principal that is due at the 10th year. Now, there's renewal provisions in the transaction where the bank can waive the tender, the put of the bond, and renew on 5-year intervals. They also have the right to waive more than one put. So they could extend you 10 years by waiving 2 puts.
Explain put.
Put means that they are giving you your bond back. They're putting it back to you, meaning you need to pay them the principal amount that's outstanding at that point in time.
When they do that, do we have to pay another bond fee or whatever you want to call it?
Well, we could conceivably find a new investor, a new bondholder to step in, or refinance into another loan facility, another bond.
Will there be a financing fee?
There could be, yes. Again, it's wherever interest rates are, what the lending market looks like, they may choose to charge an upfront fee, they may not. It depends. We see both now. Typically, if there's no upfront fee, the fixed interest rate is a bit more expensive. So they're essentially earning that fee over time rather than upfront. But yes, the district could conceivably incur additional costs if a refinancing is required, if there's a put.
And at each put, it's re-amortized.
Yes, yeah, you would recalculate given the remaining years and whatever your new interest rate is.
Is there anything that in 10 years that rate would be tied to, so we'd be assured?
Yes, it's formulaic, and it's the same credit spread in the future as it is today, but instead of a 10-year index rate, it's a 5-year index rate. Because you have one bondholder, one investor, we can mold this and rework it at that future point in time to our liking. So if the district is really continuing to improve financially, you would be in a great position perhaps to refinance or to renegotiate, to open up the documents and work with the bank to have more flexible covenants, better pricing, etc. So that 10-year point, yes, there is a potential for a put or perhaps a refinancing, but there's also an opportunity if you're doing very well.
That they could waive the put?
They could waive the put,
Yeah.
and you could also negotiate different terms, different pricing at that point also, because you have a single holder. If it was a public market deal, that's turning the aircraft carrier. It's very difficult to amend documents once they're set.
Could you mention a balloon payment at 10 years?
If the bank does not waive the put, then there is a certain amount of principal, essentially the remaining 17 years that would need to be refinanced, or we would need to find a new investor for that portion.
Your initial 2 years, if we only spend 12 million, for instance, that other 2 million disappear.
Essentially. Now, we could go back to them later on and say you were committed to 14. Here's our current financial status. We've built these projects. They're performing. We need, there could be an additional request at that point. But if the 2 years expires, the documents stipulate that you set the amortization and the final bond amount at the end of the 24th month.
Now, if there was, for instance, $1 million, and we wanted to just go ahead and take that money and put it in our reserves, could we do that? we didn't have a project.
Bond council won't let you do that on a tax exempt basis. You could conceivably take the money taxable, but we really have to run that by council and the bank.
That's one of the big issues that Hawkins is very concerned about, is that we can't use this money for arbitrage. So that's essentially what we would do. We would take the money, put it into account and earn interest. We would be using it for arbitrage, as arbitrage. And that's, that would put our tax exempt status and all the bond issues at risk. So that's not something we will ever do.
You need a legitimate project to spend the money on. Go ahead, yeah, if you'd like to flip the slide. Okay, this is, I think we all know who everyone is, but Gwen's been working with us very closely. She's helped review the commitment letter and term sheet. Gwen will also be working with Ann on certain legal issues as we move forward. So there's a lot of good eyes on this transaction. It'll be my first time working with Ann. I've actually worked with Gwen in her role at Oregon Facilities Authority previously. This is a recounting of projects and current estimated project costs. The CT scanner is one item that's to be determined. I don't want to speak out of turn, but it's my understanding that that device, that machine may cost less than $500,000, and the interest rate that's being offered might in fact be lower, more attractive to you than the 10-year rate we're getting from Washington Federal, because it'd be a 5-year lease instead of a 10-year rate. So some thinking to do, numbers to run on our end, just to make sure that from an economic standpoint and administrative standpoint, it makes sense to go one way or the other, basically. But we do have a commitment for it from the bank, which is good. So if we choose to wrap it in here, we can. If not, I think we would reduce the facility to something less than 14 million, so as not to incur, or to not pay the bank an upfront fee on really practically plan to spend.
Question on the ambulance facility, Charlie, the 1.76, is that based on a square footage number? How did we come up with 1.76?
It was a rough estimate. The way we got the estimate was Pinnacle offered us a basic schematic drawing that we provided to the ambulance organization and said, would this be something that you might like? And Detroit was doing the construction project for long-term care, said it would cost roughly, and Pinnacle said it would cost roughly. Now, since that time, the ambulance group has said, we'd like it a little bit differently in some different configurations. So we're hoping that that's good enough. Honestly, nothing's been designed. It's a cost per square foot estimate. And we would not be, it would be built on hospital, or on district property, so we wouldn't incur the cost of it. We'll have some infrastructure costs, plumbing and geothermal and that kind of thing, but we own the land.
And one of the sales features of your company is that you would earn your keep. How does that fit in here?
Sure, value add, right?
You get a percentage, don't you, of the cost of
No,
issuance?
we don't get a percentage.
You don't?
We actually offer a flat rate.
Oh, okay.
So it's not to be incented for a larger issue size. To answer that question, let's flip the slide here. So no, this is good. This is good. So this is highlights of the commitment letter and where we're at today, and we've hit on many of your objectives and goals in negotiating with the bank. I'll also say that, and we'll get to this, but we're going to have to keep a very tight timeline to close at the end of October with legal counsel, document preparation, review, and basically getting to the finish line as close as we can to when the 60-day IRBA public notice period runs. And that's on the 17th of October. So we'd like to be ready to pre-close and close later that week, if at all possible. In running an efficient transaction, we're going to keep your legal costs down as much as we possibly can. Hawkins and Miller Nash, Catherine Shaw, who's representing the bank, we think her fee can be much lower than it was on the prior transaction. The reason for that is we have a prior transaction to work from. So there was a lot of drafting of documents that was from scratch. She had to build a new continuing covenant agreement and negative pledge agreement on. So we've got documents to work from. So the value we're going to add is an efficient transaction and drive towards cost of issuance that, quite frankly, should be lower than $190,000. That's a conservative figure that Ann Sherman Hawkins, she provided a conservative number, and we're building what I think is a conservative number for bank counsel. On this page, the pricing, the 2.74 current rate, that's driven by two factors. It's the current interest rate environment, what the current 10-year Federal Reserve H15 swap rate is. I'm sure that's clear as mud. It's actually a highly visible interest rate that anyone can see just by going on the Federal Reserve website. So that's helpful to be able to track it daily, basically. The credit spread is where we have more impact. Washington Federal came back to us initially at 185. Charlie Chair, we felt that was too high. That was unreasonable. They've agreed to 175. So I think there's some value add there. They've also committed to the 175 in the future period, you know, if they choose, if they waive the put. The other thing here is that the concept of average life sort of enters into the equation. I feel that if we end up at an 8.5 or 9-year average life, okay, for that initial 10-year term, because we're paying back principal along the way, right? So it's not a 10-year bullet, your principal's amortizing. So the average life over those 10 years is likely to be shorter, probably 9 years. I'm gonna have a discussion with James if it's reasonable to use a 9-year rate instead of 10. And that would help you because, you know, the slope of the yield curve, the difference between a 9-year rate and 10-year rate might be 8-10 basis points. So we'll see where that goes. That's not contemplated in the commitment letter right now, but it's something we've done before. I would also say that in terms of our value, I think in preparing some of the financial analysis and the credit package, I think we were helpful to the district in making a good case for a $14 million commitment. In thinking through the numbers, and incorporating a 2017 budget, not just historical figures, but some forward-looking analysis, which certainly helps. If you would, one more.
One more
And
slide.
I'll come back to this slide.
Okay,
yes.
go down to here.
So here, yeah, that's good, thank you. So here, in working through that financial analysis with the bank, instead of being at a 125 coverage ratio, they're moving you down, creating more flexibility to a 110. They're comfortable with Lake Health District as a credit. They also recognize that you're embarking on some strategic projects that will take maybe a little bit of time to ramp up and generate net new revenue and even be self-supporting. So the 110 provides you with some additional cushion and flexibility instead of the 125. Another thing, when I looked at the 15 document, this stuck out to me. You have, is it 8 million outstanding? I'm trying to recall the amount. 7 something on the GEO bond, right? That your GEO bond. You collect an equal amount of property tax as debt service. That's really not going to change over the life of that bond. So the coverage ratio, the way it was written previously, didn't allow for that one-to-one offset. So the district was having to actually generate more cash available for debt service to cover the UTGO bond debt service at a 125. So that's on $450,000 roughly of debt service. That's an extra $112,000 of net cash available that you needed to generate just to meet your covenant. That's unfair because it's a one-to-one. So they've now allowed for that to be an offset and excluded from your revenue bond coverage ratio. So I think there's some value in that. I'm estimating additional cash flow cushion of 45, but that's at a 110. If it were 125, it'd be over $100,000 difference. So that creates some cushion. That also creates some capacity for $14 million of additional bonds. There is another thing that we need to mention or discuss. And seeing the July numbers that Cheryl presented, the bank asked really good questions through their credit review process. Cheryl and Charlie did a great job of answering them, but they've become more aware of the district's relationship with Goose Lake Medical and Lakeview Gardens. And there's been some transfer of assets to those organizations. They want to pick up on that, or they have picked up on that. That's now a concept that's embedded in the coverage ratio. So if there's money going to those organizations, it would be accounted for, but it would also be accounted for as it comes back.
Let me ask a question. In our 122 days, does that include just hospital, or does that include these other two?
That doesn't include that, just the hospital.
Just the hospital?
Yeah.
So if the bank looks at this, then they would give you credit for the money sitting over Lakeview Gardens.
Well, they not only give you credit for that, but they also will take into account the amount that's owed between the two entities. So what they want to kind of do is put a little pressure on us to make those entities keep in profit.
We're doing the same thing.
Right, exactly. They, so it's a good thing.
Yeah. But you had 400,000 covered.
Right. That's right.
That is cash on hand.
Yeah, it could be.
That's a really good point. I want to look at the current days cash on hand definition again. To see if that's something we can account for. Why not boost your days cash? Yeah. The current covenant and the future covenant on days cash on hand, by the way, is 90 days. So really no change there, and the bank in its credit review didn't focus on that quite as much in terms of the raw covenant. Let's flip back a page, if you could. So they've now incorporated the concept of a performance premium. And I view this as neutral to perhaps somewhat negative. That's what these little indicators are next to each head. Green with a plus means better or positive. The orange star, neutral. The red minus, different and not positive. I don't want to say negative. So the bank sees, they're committing to 2 projects that have yet to get off the ground. So there's some uncertainty with the clinic renovation expansion and the ambulance facility. Charlie knows, Cheryl knows, I've heard this, I know, that I think the district is going to get there on those 2 projects. I think the current estimates are reasonable in terms of the cost. I also think the impact of the district will be positive, net positive. So it will bear itself out, it will prove out. But that uncertainty always makes your lender, a credit officer, a little skittish, right? So in reducing, giving you more flexibility on your coverage ratio, and committing to projects that aren't, gift wrapped and presented to them, they've introduced this concept of a performance premium. So let me walk you through this, okay? The performance premium would be an additional 35 basis points on your rate. So practically speaking, if we lock the rate today and you were not performing, given these metrics, your rate would be equivalent to the 15A bond. So that's how much rates have actually moved down, okay? But let me walk you through this. So if days cash on hand is greater than or equal to 135, the premium will never apply. If days cash on hand is less than 135, but coverage is greater than 140, no premium. It's only if days cash on hand and your liquidity position, your days, if your days cash on hand is less than 135, so you're not quite as robust from a liquidity standpoint, and your coverage is below 140, they would apply this premium. And it's tested annually based on your audit. So it's not a quarterly thing, it's annual. So you would live with the 35 basis points until the next year where this would bear out. Given Cheryl's report, and you're currently at 122 days, you've got impact of mental health dollars, you also have the impact of you're being reimbursed through the bonds. You're actually getting liquidity back, which will boost your days cash on hand. There was actually quite a bit of negotiation that went into this. James wanted to purely tie it to coverage. I said that's unfair. You appreciate and enjoy the district and its liquidity position. You've always mentioned that as a credit strength. Let's reward them for that. So 135 is 50% higher than your current covenant, 90. It's an extra 45 days. So if you can stay above that, you're good. This will not apply. So that's why I view it as not positive, but I think with good management, prudent management, how you operate, I think I would not expect this premium to ever be triggered.
Yeah, I still have to, I haven't in my mind got coverage quite figured out. What would, if you took the last audit, what would be a number for our coverage?
I can answer that if you
Oh,
want to
yeah,
share.
I don't know from the last audit, I'm sorry.
Okay, so when we ran the 2016 numbers, which that's not necessarily audit-based,
Okay.
but we used where you felt the district was finishing fiscal 16. Coverage, I took a note here, was just over 2 times. But that doesn't account for the new debt. So when our pro forma for 16 and 17 using the budget, which, in looking at that, there's some conservatism in your budgeting practices. It was a 135 is where we were with all 14 million.
That's using all 14
Right.
at one time.
At one time.
And we
That's
would
correct.
have spent all that
Right.
during that time.
Right. With no additional revenue associated with the ambulance facility, for instance, or additional net revenue that would come from these strategic investments. So it's really like a historical measure in a way, that you're not accounting for kind of where the district is headed over the next 2 to 3 years, once the draw period ends, for instance. That's a fully loaded $14 million, 3%, 25-year amortization, level debt service. So that is conservative, quite frankly. But we felt that you have the capacity of borrow at 135, given where that metric comes in.
Anything else?
Let's flip to the interest rate graph. I think that would be interesting for you, right here. So it might be hard to see, but can you see the green oval in the middle? There's an orange line, there's the blue line, and then there's 2 green ovals. The first green oval is October of 2015. That's where you locked in your interest rate on the 15A bond. The green oval to the far right is where we're at today. So,
Right here.
and again, that's about a 35 basis point differential today versus where you locked in your rate 11 months ago. Thank you, Brexit. Seriously, the event at the end of June just, and quite frankly, how the U.S. economy has been doing lately, and the positioning of the Federal Reserve and their stance on interest rates were low. I will tell you though, that we will lock in this rate and close before November 8th, before the election. Because who knows after that. And I don't want to say that interest rates will move exactly, one way or another, depending on which candidate prevails. And Charlie has his own views on that, but I want to avoid it. I have 2 other transactions. It's like we're going to be done at the end of October. So, yeah.
Any other questions? John, thank you very much.
You're
I
welcome.
think you're
Thanks for
earning
your
your
time.
keep. I'll give you credit.
Sure, sure.
Very much so.
Yeah, I typically don't like to be so direct about that kind of thing, but yeah, okay, fair enough. I like to be more humble. I appreciate your
See, you're
question.
teaching us. We're
Sure, sure.
Not only that, trying to read through those documents, it's just kind of like making my eyes cross.
Yeah.
I'll be glad that you don't have to read the continuing covenant agreement or some of the other documents that come with the transaction.
Just keep us out of trouble, that's all.
Absolutely, that's what we're here for, that's what Gwen is there for, and quite frankly, that's what bond counsel Ann Sherman is there for.
Is
So,
there any board action you need at this point?
no. Again, so the state of Oregon, Constitution of Oregon, requires a 60-day public notice period for revenue bonds. It's the URBA, Uniform Revenue Bond Act. The 60-day notice was published on August 16th, I believe. So 60 days is, let's say, October 16th. The board can actually take action. The 60 days must run its course before you do anything, before a resolution can be passed. But I've spoke with Charlie and Cheryl, and I think, I don't want to speak out of turn, but I think he will be looking to schedule a special meeting on the 17th, that's a Monday, to authorize this transaction. We will have final documents. We will be ready to close at that point in time. We're allowed to do work while the 60 days runs. So just keep that in mind. But I think that's the next time the board would be asked to take action.
17th of
October.
October, okay.
Right.
So we would have 2 board meetings, one for regular business, and then one just to approve documents.
Okay.
And then if all goes as we hope, then I would immediately, or very shortly thereafter, head to Portland to sign the documents, which is what we did here.
Very good. Thank you very much.
Thank you.
Thank you.
All right. Healthcare facility protection and health information report. Who's gonna handle that?
I'll talk a little bit about that. Sheila and Stephen were going to be here, but are not actually here right now. The Oregon Health Authority has asked that we acknowledge, and I think, did this get all sent, a letter, copy of my letter get sent out to you?
I think that, the one that
Yes.
says that we're protecting our information.
Yeah.
Yes.
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 So we're doing a couple things to.
Go Broncos.
We're talking on the phone. That's right.
Thank you, John.
We have a conference call with the bank tomorrow. So he's going to take the call where he can. So, anyway, as I'm sure all of you have been following the breaches and the risks that are going on with hospitals, and the fact that we have lots of data, people are trying to capture that. A hospital not very far from us, not only did they have a problem occur, but they even had to involve the FBI because of ransom. So we're taking it seriously. We have engaged a firm called Clear Data that we will be using to help us monitor our risks and ensure that we are protecting our data, protecting as much as we possibly can. And we do a lot of things to try and ensure that people can't access inappropriately our health information. But for example, we don't allow, although it could potentially happen, anybody to put any patient data on a laptop. All desktops, the information is not stored in the desktops. It's stored on our servers, so that if someone were to steal a laptop, they couldn't get patient information because there's nothing stored on it. And then it makes it harder to get to the servers, and we have lots of protection. But even with protection, there are issues that have been coming. So the letter that we've sent out, the healthcare facility protection of health information report, we're doing a lot of things, and we are stepping up our involvement to ensure that we don't have this problem.
Now, your cows don't have a current patient's data on it?
What they have is, it's stored in RAM memory. It's not actually stored on the computer.
Okay.
So what it's doing is it'll access it, and then it's sitting right here as soon as you,
Wi-Fi. Yeah.
and then if you were to turn it off and take the cow, none of the information would go.
Okay.
Okay, so it's not resident on the computer. It's just accessing that information. Now, that doesn't preclude someone from taking one of the mobile care stations, nefariously pulling up data, if they had the passwords and they had all sorts of access. And we work very hard to try and protect that, limit access, how long it's available. And we're doing, but there's always smart people to figure out things that we wish they did. Anyway, we'll be giving you more and more information about Clear Data is a known company that does a lot of work to help us in our data protection. We can buy insurance to protect against us having a breach. And I struggle with whether or not it's worth the money, because it's a lot of money. We are doing a lot of things to protect that. You buy insurance for everything. Sometimes,
Yeah. Our insurance doesn't specifically exclude coverage for that under the umbrella policy, does it?
doesn't, but for example, if there was a breach, we could be liable for every record in terms of the fine. So a lot of times what the insurance will do is, if there's a data breach and a company, and so suppose a bunch of people's social security numbers were accessed in that data breach. Every single individual, you would buy protection from companies to protect against their data being sold and a credit card being purchased with their social security information.
LifeLock or something.
So you buy that kind, and so that's what insurance buys for you. And also there is a fine for every individual record that is stolen. That's really what a lot of that protection is getting for you. So I think it's really prudent to focus on our actions, what we are doing, rather than buying necessarily insurance to protect what if. But rather, let's focus on how we're doing it. So we will come to you with more of this kind of information as time goes on.
Well, it's got your name on it,
Right.
Okay. Thank you on that. I appreciate that.
All right, Partnership for Patients, Nom.
Yes, so I wanted to briefly talk about Partnership for Patients. All of you got this stoplight report in the packet that was sent to you. No, sorry. Thank you. The stoplight report that was sent to you in the packet. And so this Partnership for Patients is a federal initiative that was started last year. It is the second time that the government is starting this program, and it is geared towards increasing patient safety, reducing patient harm. And we are one of the 4 independent critical access hospitals in the state of Oregon participating in that. This is not a required program, but patient safety is one of our priorities, and so we are participating in that. There are 21 different measures that we are following through this program, and we are doing very well with most of them. There are 6 measures in which, if you would have seen, we were in red, but that is marginal. But I would like to specifically talk about one measure that a couple of you mentioned, where we were at 333% and we should jump out at. So one thing is that this measure has a very broad definition. What this measure is doing is it is looking at all the patients who had come to the hospital and expired or passed away and had a diagnosis of sepsis. But the problem with this is that it does not say it has to be the primary diagnosis. What it means is that if a patient came in with a liver disease and had sepsis as an additional problem, then they fall in this criteria. So I looked at all the patients at our hospital who were under this criteria, and all of them had other critical issues, healthcare issues that were being addressed while they were here. And sepsis was not their primary diagnosis. That was not what they were being treated for. So the way this definition has been defined by the government is not very medically sound, and that's the reason we are looking at 333%. But there were patients with complex health issues that were being treated and not for the disease that we are looking for. That's the primary reason, but we understand the importance of identifying sepsis at an early time. And so Abby, who's our ED nurse manager, she and I have worked together, and we have educated our nurses on the new definition that has been put out, and we have shared that with our providers as well. They have agreed, and we are working on a better plan to identify and get everybody on the same page for sepsis.
Thank you.
Teresa, would you like to add anything?
Well, I think that we see, we kind of have a plan for sepsis. I think that we see improvements that we can make, and we've certainly done quite a bit of work on this in terms of educating nurses and developing some quick tools to help them. I think that some of these are relatively new to us, and so we're learning how to deal with them, and maybe we need to focus on them more, but it does take time to make these kind of changes. But the biggest issue that we find is low numbers.
Mm-hmm.
We look really bad when 1 out of 2 patients,
Sure,
it just,
right.
it's a
See
big,
2
it's,
patients on like on this one.
yeah, it's a fight.
Just takes one.
It does, yeah, it is. So I mean, I guess that's all I could add. Has explained it far better than.
The only thing I would say about the low numbers is, it's true that there are low numbers. But you know, for every one of those, if there's 2 patients, those 2 patients are important. We ought to be paying attention to it and still focusing on what we can do to improve our care, even if it is for small numbers. So the benefit of these reports, if you think, oh, we're doing great all the time, what we really want to look for is areas that we are not doing as well, and how do we improve ourselves. That's really what it's going to tell us. So it is important to pay attention to, even with low numbers.
Thank you. Nursing report, Teresa.
Yes, I told Charlie I would just kind of update you on nurse staffing. We've had a lot of changes in the last 6 months, I think. I would say a lot of changes in terms of people that we knew would be leaving, but now they have left. So we have a lot of training going on as you guys know, it takes us quite a long while to bring a new nurse into our hospital and have them learn all of the areas that they have to know well. So we're working on that, and we did a trial, which unfortunately didn't work. We did have we were approached to take a nurse from the Philippines who had a number of years of experience. So we gave it a go, hoping for a nurse with experience that would be helpful, but that didn't end up working out for a lot of language issues. So I don't know if you all get feedback on those kind of things, but just thought I would tell you about that. So we continue to have applications, and I have really good candidates out there, and we have Miranda who will be hopefully taking her boards in another month or so. So we do have good things happening, but we're in the transition phase, and so everyone has got their shoulder to the wheel trying to get through this particular time. Nurse managers have been working a lot on the floor, and we anticipate that may continue. This is a busy time of the year for us, usually in the fall. So just, I thought I'd update you on that. And then I guess we have a little update on the meaningful use issues. So meaningful use, as you know, is the government's way of measuring how well we use our electronic medical record system, health information system. So they expanded some of the measures that we have to comply with over the past year. And Diana Truchter has worked really hard over the whatever length of time she's been here. I guess it's probably been 6 months now. And I have to tell you that she's made a big difference. We are completely in compliance with all of the mini measures. So that's positive. And we don't have a report here in front of you, but so far so good. There's a lot of things that are difficult to do, that are very difficult to do. One of them is electronic prescribing, which our providers don't find easy to do in our current environment. It's not easy for them at all, so it's not something that they like doing. So those are the kind of hard things that we've had to do. She's also made a difference. We have a number of interfaces which provide data to state reporting sites on things like particular diseases that are mandatory reports. There's some automatic information that goes to the state, and she has made sure that all of those interfaces are working well. So far so good.
Very.
Hopefully they won't reduce our payment next year, that's the goal.
And I would ask that, everybody here should go online and take a look at the
Portals?
The portals. We got 2 portals, one for the hospital, one for the clinic.
Mm-hmm.
And I used the clinic the other day to make an appointment with Dr. Gallagher. So
How did it
I'm
work?
a month out, but they'll get there.
You got it.
But I got it, yep. I actually got an answer back from Linda Wells, and we made the appointment, so.
Good.
And the data that's on there is fairly recent, but as we go along, I'm looking at getting more and more of my data on there, so that if I ever go to another doctor, it's real easy for me to just pull it up and do it.
My only complaint with the whole system is that you should have one portal. Every doctor you go to, you've got a different portal.
Every electronic system is different. And I think that, Dawn and I heard this from our Patient Family Advisory Council. I think the one for the clinics, either Dr. Graham or the hospital clinic, both of those seem to be way more helpful. The hospital portal just doesn't have a lot of information, I think. There's lab information on there, but other than that, in terms of the reality of things, that people don't need to get on that portal as much.
I have yet to be able to get on that portal. I have had multiple passwords, I don't know why. I've given up, to tell you the truth. I haven't even tried it.
So one of the things that we're going to do to encourage and make it easier for people to access the portal is we're going to do a Get Portal program going and have the informatics team and other staff members ready to help people. Have a help desk, make it easy, walk through the process so that we can get as many people accessing it. Because it is cumbersome. In fact, when Cheryl and I were in the recent meeting that CPSI put on to talk about where they're going as a software company, they're actually now, CPSI has multiple software programs because they bought Healthline, which was one of the software vendors we looked at. And they said that what they have learned is that their portal stinks, but that Healthline has a better program for doing their portal, and they're going to be, as they work the two programs, they're going to try and get the benefits of Healthline's portal onto CPSI portal.
Teresa, on there, does it have any way to report if it's not up and not working? I had someone that utilized it, but said, I know you got a lot going on down there, but your portal
I've never
is
been
not-"
on the portal, Tom.
But Amy,
We're going to really promote it.
Well, Amy Riches and I have been kind of working on the website versus the portal issue. And number one, we had to take the bill pay down because it wasn't connecting right. And so we were having a lot of issues where payments were being submitted, but they weren't actually processing. So money wasn't actually coming from people's accounts. The other issue is the issue like Judy was reporting with, you know, you get signed up and then your password wouldn't work and then it'd re-sign you up. And so Amy and I were actually going back and forth working on that recently, and I explained to her some of the reports that I had received. Both, I'll get some feedback on the website because I get those contact us forms. And so I always pass those off to her and let her know, here's some of the feedback we're getting. So that's something, but we can also look at possibly maybe putting a contact us link with the portal portion on the website too.
I think that'd be
so that
helpful,
we
because
can
this
do that.
individual utilized it, knew about it,
Mhm.
but was unable to get the information and didn't really know who to go to. or what to
Right,
do.
and I think it's kind of new that Amy's taken that over,
Right.
that's something that
Okay.
she's starting to
Now,
work
the
on, so we can
instructions
do
on
that.
that page are unclear, actually.
So she is working on that.
Good.
She's
Okay.
taken on that issue and she's just finished. That was another thing that we talked about is there's a flyer that we put together and she's now combined the information about the hospital portal and the clinic portal. So you can get that one flyer and it'll have a contact person if you're having trouble
Good.
within the flyer. And I saw that she's on her second draft of that. So we are getting closer. Sorry about that, but
I think we sent out a copy.
I'm honest, so you should know that.
To take a look at it.
Another subject, and maybe you don't know, Teresa, we, a couple of meetings back, set up a new program for CNA training for
The scholarship?
funding a few people, yeah.
I believe Melinda did that. I did not have,
Larry and
did
I
anybody
said
get a
yes.
scholarship to go through that last program?
Yes.
Yes, there were two.
I was thinking there was two.
Okay.
I didn't have the good luck of having a candidate that wanted to, I have somebody that is thinking of it, but she didn't end up going through that class. So we're still hopeful, and she is getting ready to do another class, I believe.
Yeah, applications are available starting today.
We did interviews about, what, a month ago, Larry?
Right around a month ago, maybe 5 weeks ago.
So you had 2 recipients?
One is no longer in the class. But one of them is finishing up their clinicals Monday, and they'll be graduating from the class on Monday.
Where are we with the RN program at the ILC? Is that up and running? Are we doing any of that?
Tell you the truth, I don't know exactly. That's a good question, I should have had an answer. I'll find out. I can't tell you. Do you know?
So they graduated the first, the bridge program. That's what Miranda was in, the bridge program, LP into RN. They have accepted applicants for the 2-year RN program, and that starts this fall. And we have 2 people that were accepted into that program. One is from long-term care, Jolene Ray, and one is Kylie Leach, who's a PRN CNA on my
Those are the 2
side.
that under the 80.
So those 2 are going to be entering the beginning this fall. So
Are
they'll
they
be
able to do it here?
The only thing they can do here is 2 days a week they can attend in our classroom that we have here on site. They attend classes. They've been requiring all clinicals to be done in Clements.
Is it every other Saturday?
No, that's for the anatomy, that's a pre-rep. That's for anatomy and physiology. It's Monday through Friday, or Monday through Thursday, I believe, and out of those days, 2 of them, they're able to do their classroom here. The clinicals, the only clinical that was done by Miranda was in her last term here, so, yeah. So I believe there's quite a bit of work to be done yet.
Have we ever paid that portion of the salary we were obligated, or that we agreed to pay? Never done that either.
We pay a very small amount.
What did we didn't we say 75,000, something like that?
Yeah.
So we're moving into Leslie's report. Let's go ahead and do that.
Yeah. No? Are we going to do this or no?
Sure.
Oh, there's one more thing.
There's one
She's
more
still
thing
going.
that you got. I said no.
I know you did.
Or should you want to say anything about it, I guess?
I just wanted to share this with all the board members. This is our latest age gaps report. That is the patient satisfaction survey that we do on the hospital inpatients. And we use a third-party vendor called NRC to do that. And at this point, we are done with receiving the Q2 results. The Q3, as you see the yellow ones, they are still rolling in. We usually see a response rate of 37%, that is approximately 24 to 26 patients every quarter. So something that was alarming for us was in Q2, we had only 12 patients who responded to the survey. The results are really outstanding. We are in all green. We were doing really well, but our response rate has gone down. So I will be working with the nursing staff and with tree staff to put some education out there and promote the survey. We want more patients to give us feedback about their visit in the hospital. So I thought I'd share it with you, and we are working on improving our response rate. So hopefully for Q3 maybe, but Q4 we will again see our response rates going higher.
Good.
But it's all green. The good news is it's all
Yeah.
green.
It's really good.
Yeah. There's no bright red on there.
Okay.
All good.
All right, now we'll go back to Leslie. Thank you.
All right, so there are 3 applicants for the Patricia Fund. One of them is ongoing. She's in her final stretch at OHSU. Her name's Edwina Arrington, but she goes by Hope. So you have approved her, and she's continued to successfully pass the courses and continue on the program with OHSU. So she has applied for the last 3 quarters for fall, spring, and fall, winter, and spring this year. So I would like to recommend, I guess I should present all 3 and then I'll give you a recommendation.
We've seen 2 of them.
2 of them, we saw the application for.
Yes, and I did not have
Hope would have been the
hopes.
3rd one.
Hope would have been the 3rd one, and I
And
did.
how much is her request?
8,400, which is what she received last year, and that is the maximum of the stipend. All of them have requested the maximum. Fees have gone up. If you looked through the requirements of the courses, just for fall term, you know, they've got all of these one-time purchases for, you know, products and digital books, and it's, you know, almost $4,200 just for their first term at Klamath for their associates. So it's quite costly. I don't have a history on the fees, but they tend to go up. So they've added some things that were not in there in the past. And so they all 3 have requested the maximum. Now, we can go, if you like, quarter by quarter for the new applicants, so that, you know, if we see they're successful, then, you know, if you would like to award them $2,800 this term, which they would receive obviously on completion, then we could look at approving an additional $2,800 for the following term. I guess it depends on what you're more comfortable in doing, or,
But if they didn't get good grades, then what do you do? If we've already approved it?
they don't, well, they've got to successfully complete their courses
So
in order to for
How are we
reimbursement.
dispersing the money right now? Normally, when I disperse on scholarships, we send it to the registrar.
So
Disbursement.
they pay and we reimburse them.
Oh, okay.
So they bring their tuition receipt to us along with successful completion of their grades, and then we reimburse them. So when you approve it ahead of time, like with Hope last year, she spent $6,800 on her first term. So her second check was for $1,500 because the maximum stipend was $8,400. And not having a history here, I'm not quite sure how you do your approvals, so I'm kind of looking to you.
I have no problem with approving a year at a time.
Okay, all right. Then I would like to recommend that all 3 applicants, Hope Arrington, cut that out. Jolene Rhea and Kylie Leach each be approved for $8,400 for the 16-17 academic year.
So moved. I'll second.
Moved and seconded, those in favor?
Aye.
Aye. Thank you.
Thank you.
Oh, one last, how much is left in the fund now after?
I knew you were going to ask me that.
Yeah, I'm dollars and cents type guy.
And I should have, and I did think about that.
We'll get that information.
We'll get that information for you.
It's gonna be in the 70 to 75,000.
Yeah, because I think it was 88,000.
Yeah, when you're done with
How
it.
how is that reimbursable? How does that fund continue to grow?
It isn't, we have to.
You have to
put money
replenish
in.
it.
Okay.
Yeah, it
I think
doesn't
I asked
grow.
that before.
Right.
We've talked about this.
They sign a note, and if they leave early, they have to repay. But
Correct.
If they continue here, then it's not
But if it
repaid.
gets
How long
down
will
to
they
where
have to
it's
stay
close,
here
then
before
we're
they
gonna
have
want
to
to fund
repay?
it. Some more.
We may want to put
Right.
some more money into.
3.
Okay, moving
3
on.
years. 3-year commitment.
There's a mistake here, it says mental health, but I think it's behavioral health.
Yeah, that was my fault.
This is for the board.
So one of the things that was asked is that we give you an update and on a regular basis of what's been happening with the behavioral health department that is now called behavioral, it was the county mental health. It has been a challenging time, but then we knew that would be the case. So, but there are a lot of positive things that are happening. We've hired 2 therapists, Trace Wanser and Kylie Thomas. Kylie started on Tuesday, and Trace will start on the 26th, I believe is the date. So that's a really a positive thing. Both our master's trained, Trace will be our supervisor, clinical supervisor. And depending on how well that goes, she may become our executive director. waiting to see how that pans out.
Are you fulfilling that role right now, Charlie?
No, we have contracted with a company called Community Counseling Solutions. They're based out of Hebner, and so I can't fulfill that role because my advanced degree is not in as a clinician. So we have to have somebody else that will do that. And we are continuing actively look for good candidates. We've added a case manager. We are looking to add at least one, if not two more case managers. Case managers are people that function very much like our navigators that help patients, help clients get to their appointments in some of the, not as therapy, but in other services to work with.
They don't have to be certified in the same thing.
They have different, different kinds of educational requirements and on-the-job training, that sort of thing. In looking at the building that we have taken over, as you know, we are leasing it for $1 a year from the county. Found that there were several issues that we had to address. We started out by cleaning it up and moving some of the items that were stored in places that would make it unsafe and potential fire hazards and that kind of thing. Soundproofing has been a problem. Because of the way it was built, it didn't really accommodate truly confidential conversations between the client and the therapist. So we are putting in soundproofing, which is blowing insulation to the walls, and we are, there's a product that's made to kind of like those headphones you can buy in an airplane that emit dead noise, and so that will be able to be spread throughout the facility, and it will actually create dead sound, so we'll have it much more protected. We have to fix the heating and air conditioning system. We've gotten a couple of estimates. The total cost for all of this is in the ballpark of $60,000. And we really don't have any choices. We've got to get those things fixed. So we're working on getting that taken care of. As you heard, we transferred, the county transferred $800,000 to us on Tuesday. So that is the first part. There's about $1.3 million total that the county has. And the other part of that will be transferred when we sign the Gobi contract. I have the Gobi contract. I have been reviewing it. There are some stipulations in there that are a little concerning, but not overly concerning. It's not for, it's not an evergreening contract. It is a 7-month contract, which makes me a little concerned. They have some stipulations about how we have to improve the service significantly very quickly, which we don't. But we're still in the contract review process. We are engaging with their software, which is another software program that we have. It's called Credible. It's a, as you may imagine, software within the mental health department or behavioral health services has to be very protected because it is not just HIPAA protected. That information may be, it's one thing for you to know whether or not I went to see a therapist. It's another thing for you to know that I talked to about my personal issues. That's a different level of security. So this Credible software is what is used throughout much of Eastern Oregon for the behavioral health services. And so we're going through training and getting all of that process worked out. The county has been working with us and with Gobi, because Gobi has been providing some of the internet service. Stephen has estimated it'll be another 2-3 weeks before we can actually make all the transitions and everything work real well between our systems and their systems. We're in that process. We have been approved by several of the insurance companies for delivering service outside of just Medicaid services. and we hope to have the rest done once we finish our Kobe contract. Looks like we will have a survey from the state, the 22nd and 23rd of September. So if you recall, we were granted our CMPH, Community Mental Health Practitioner certification to take over this service. They granted that for 6 months, and we had a variety of different things we had to produce. Some things we did not have because the county didn't have. A perfect example of that is we had to provide them with the last 2 fire inspections within the last 4 years. Well, the facility up in Christmas Valley the last inspection was in 2001. We couldn't get it any sooner. So we're working through all that process. And we are finalizing our arrangements with the Teamsters for transferring all the employees and all the components up there. Any questions about what we're doing and how that process is working?
I have a question. Are we looking at the Marius building? Are we looking at the entire building or just looking at rooms in the Marius building?
Okay, there's several answers to it. Number one, we have an office that came as part of the agreement, and that's on the second floor for the prevention office, and that has been there for some time. So we already have an arrangement there for that service. And then we talked about the challenge that the department currently has in that there are times that it's inappropriate for certain kinds of people to be in the same waiting room or in the same facility. Children and adults at the same time or different kinds of conditions. So we talked about possibly using some additional space, and one option was in the Marius building where the probation office is, where Jay Greer and his team have been. They are moving into the county courthouse, and it was supposed to have been by September 1st. Looks like, according to Jake, it may be next week that they actually move out. And so what we've said is, I've looked at, is that a possible place where we could either split the alcohol and drug, or it's addictions versus behavioral health, mental health services. And that might be a good way of separating. And so there is a possibility that we would lease that space from the building owners. The building owners have been very interested in encouraging us to consider buying the building, but we listen to a lot of people ask us a lot of things. So we take a lot of things under
Yeah, I
consideration.
don't mind leasing the building, but I think you'd have to work real hard at buying that building.
I agree.
So,
Charlie, my other question is, how do we have enough maintenance staff to do all of this? Are we needing more maintenance people?
Yeah. And we have been looking for, we've been looking for a couple of people. We changed a little bit on our definition of maintenance crew. We're in the process with the Teamsters on this. Right now, we have a definition of just maintenance work, and then there's different skill sets that people have. And we're moving toward a definition of a maintenance 1, 2, 3, and 4 to accommodate the different skill sets that different individuals have. We've been looking for, if we're going to do a lot more of the construction, we want to have not only like with Shane Robinson's a perfect example. For them to be very efficient, they need to have a helper, which would be a maintenance 1. So we are looking for people that we can find that will do that work. So we have been actively looking. I mean, there's a lot of things that we're doing to accommodate this growth. We've had the same issue with billing, we've had issues with, there's just a variety of different issues as we take on these responsibilities. IT, the informatics team that we have with Diane, with Amy, and with Lisa, each one takes on different types of software. They become sort of experts in those areas. They cover for each other. But we have to designate one person who's going to be an expert in credit. We have to have one person who's a sort of an expert in the e-clinical, or one person who's in, they all have to know CPSI, but one, they take on different roles. And as we keep adding more software, those interfaces are important.
Charlie, have you thought about breaking out the groundkeeping? I know sometimes you might have a $15 an hour guy doing a $10 job.
We do have the opportunity to have some people that are a little more focused on the external, and that is in part seasonal. So we have one individual who predominantly, not always, but predominantly handles outside in the summer. But then we also have during the winter, when the big storm, we got everybody out working out there, or something to that effect. So it's a combination, but we do kind of focus a little bit on that. And now that as we have more locations, we need to make sure that we are able to accommodate, like, all the sidewalks everywhere, those kinds of issues.
Can I interject just a tiny little bit? Is that okay?
Yeah.
So that's what the categories for the 1, 2, and 3, so that it would fall under maintenance 1 versus, somebody that's got a much higher skill level. So that those responsibilities as we do the essential job functions, that will be designated underneath the maintenance 1. So the wage will correspond with the work.
Okay.
Other questions about mental health?
Let's go ahead for medical staff privileging. I think we were all there at
Yeah.
noon today.
So you heard what the medical
We
staff.
heard what they
agreed
agreed
to.
Correct, we were all there, so I would move that we approve the medical staff privileging
I'll second that.
as it was presented.
Moved and seconded, those in favor?
Aye.
Aye. Thank you.
Thank you.
Employee recognition.
It's always great to think about all the great stuff that our team, our staff does. We have exceptional people. Once again, though, we have an exceptional team that I think has really gone above and beyond. And in this case, we put on 2 pretty big events. One was a triathlon that we put on for a lot of the kids, and home health also was involved, instrumental in putting together our employee pick. So employees of the month of the home health and hospice team, they really did an exceptional job. And it's great for our community, it was great for our employee community. So appreciate all of it.
Very good.
Good.
Thank you. Well, Charlie, you can report to us now.
I'll try to talk fast. First off, our Lake Health Medical Supply Company, our durable medical equipment company, one of the things we had been waiting on was for our survey for us to become a Medicare-approved facility. We paid a company, because Medicare doesn't actually come out and do the surveys anymore. So we paid a company, they would come out with 1 hour notice, show up and then do the inspection. They actually came out in the last 10 days. And the verbal that they gave us, and we will receive a written response within 2 weeks, they estimated, was exceptional. So they said we would be approved until we get it right. What that means is, once we have that we will be able to actively go at getting our Medicare services going, which means we'll be able to handle oxygen. That's a big deal. We also have our California license, so we'll be able to expand into California with that. It's a very positive thing. Lakeview Gardens, you all probably want to know what's happening with the construction. We received today the final variance for building out the assisted living. Amazingly, that had not been completed. What we had was, it had been approved a year and a half ago when we met with them, And then the change in architect staff. And the new group came in and said, we can't quite do this. So we had to go through another version of the waivers. And fortunately, we had to bump out for the rooms about 10 feet each. I think I sent many of you, did I send you?
In square feet.
10 square feet,
Yeah.
2 feet by 5 feet. So,
That's the room I want.
so what they agreed is that of the 12 rooms, the average would exceed the 220 square feet. So 4 of the rooms didn't have to. Originally, the estimate that was going to be fairly onerous in terms of the cost. They don't have a firm number yet, but they're estimating it may cost less than $20,000 for that expansion. So I think we passed the ball a little bit on that. So far, we have spent about $2,148,000 on the project. We will get that back, but that's on all the expenses. And I'd be happy to share you the breakout of how that's tracking, so you can see what this costs. We're still on target, still on track for completion date. And if you want to have a walkthrough, I'm sure that they'll provide helmets. I'm sure it is exciting to watch how the process is.
Can you just go out there for a walk?
They'll want you to put on hard hats
Yeah.
and safety glasses and a vest, and they'll tour you. But they stop, they enjoy doing it, so,
Do they?
yeah.
Stop.
If you check into the office, one of the team that is there,
Jim, who is the project manager, is usually the one.
he's
Yeah.
usually
Yeah.
there available, but if not, he would designate somebody else. They'd love to show you. And we're continuing to work through issues.
Yeah, yeah.
We had some issues that came up today, and they're constantly working on it.
Got a salon too.
So that looks pretty positive. This past
So
week,
completion date, excuse me, Charlie, February, March?
it's still targeted for March. I hesitate to say the exact date because, that could change today.
Depending on the weather, sometimes.
What they really anticipate is they'll have the roof in for the system where they're building these sequences as they do these things. They should have that before the snows come and they can continue working inside. But there could be some other factors or equipment or something that might delay that. So tentative date is still on target for 2017. Any questions about Lakeview Gardens? Do you want to say anything about the training that we're working on in Melinda?
Glenn and I went and toured the Oregon Veterans Home up in Lebanon, and they're more than willing to help train some of our staff so then they can become train-the-trainers. So then we can spend a couple months training our staff prior to the opening of Lakeview Gardens. So we're in the process of picking the staff that we want to send up there to receive that training.
One of the reasons this is important is, if you recall, the greenhouse project has said that it would cost about $200,000 to do all the training and to bring us up to speed. So our charge is to spend less than that to go through this, to train all of our staff. And we're actively trying to come up with plans.
Did the veterans have a similar way their employees work?
Yes, very, very much. And very much like the group in Montana that said that we toured their facility. They did not do, they originally were a greenhouse facility, and then they felt that it was an expensive program. We're trying to, if we can, make this work without spending that money, then that's money saved. So we're actively looking at that. I think we told you that we got a grant for 4 hospitals, $80,000 for lean training. Nam and Janine Sims and Juanita and Kelsey Chartier and I went to Burns last week for the initial training for all 4 hospitals on the lean program. Next week, they will start with our hospital, and they'll spend 2 days. The Purdue University team will be 2 days at each of the hospitals. Our project is to focus on the transition between the clinics and the hospital to make sure that our processes are smooth, the authorizations are ordering, all of that. So Nam has been active, Nam and Kelsey have been in the clinics observing how our processes work. It's an exciting thing when you look at and try to systematize how we do things, find where our problems are, streamline it. Hopefully we'll be able to, all of that. Our goal is, this is a year-long project, is that once we do our project and each hospital and clinic will do a different project, we're going to take all 4 projects and share with the others. So the others will learn something from us and we'll learn from them. So it's a pretty exciting hands-on program, trying to get frontline people working. So we're excited about that. On the 24th, we will have Dr. Keister and his family, I think, wife and child. And he's a 3rd-year resident, will be visiting. I hope you can be available. We want to show him around. He is seriously considering our location. If you recall, he's the physician that noticed us when he saw our National Health Service Corps approval. So he'd certainly be interested in getting local payments. And he's very interested in this program. So we'll be setting up a schedule for tour and for meeting individuals. Your input makes a big difference when physicians come to visit. The clinic remodel, as you saw this afternoon and see in the volunteer, we are in process with those comments and get a response back to the medical staff as quickly as we can, hopefully next week. Review that. Personally, I'll be involved in a little bit of traveling in the next couple of weeks. I did elect to go to Washington, D.C., and I'll be doing that. I'll be gone on Friday and come back on Wednesday. So Thursday, when the inspectors come for the mental health, for behavioral health survey, I'll be a little bit on fumes. But the following week, we have our EOCCO board meeting in Baker City, where we'll find out if and, well, I know we will get some of our monies from our, the CCO did well this year. $14 million. We should get our share of our withhold back plus some extra money. To report back on that. And then the next day I'll be in Portland, Hamilton, of the state of reform, talking about rural health and our interest in needs in Portland. Anything else I can tell you about the stuff that we're doing? We have a lot of really good staff and we're doing a lot of great stuff.
Thank you, John. Do we have any items for executive session?
I can give you just a 20-second update on the mediation if you'd like it.
Okay.
But it can wait too, is we're gonna do it